So we've been hearing from Dr. Chapin and Dr. Ravel about the screening and prevention, and I am a colorectal surgeon, and the more we screen, the more we prevent, and hopefully I'll never have to see any of you. That would be a really wonderful thing. So let's talk a little bit just about, in case you do ultimately have a colon cancer, see if I can try and make some sense out of what's involved with colon cancer surgery. But, we've been talking about the colon without really identifying what this organ is. Quite simplistically, it's a hollow tube that really starts over your right hip, goes up the right side to the rib cage, across the rib cage, down and out. And somewhere around here, if this is the anus, from here to about another 10 inches, or about 10 inches is the rectum. So from 0 to here is the rectum, and the rest of it is the colon. Colon has a simple job. It really just moves stool through, and it absorbs some water so that it concentrates the stool. I'm going to disagree a little bit with Mark. Maybe my data was a little bit older. It is the third most commonly diagnosed cancer every year in both men and women, and this is from 2009. It's actually the number 3 killer in men and women, but again, 2009. Men, lung and prostate are ahead, and lung and breast cancer in women. So it's the real deal, as you've heard. Some of the risk factors have already been touched on. I won't belabor them. Family history is critically important. Certain kind of inflammatory conditions of the colon, such as ulcerative colitis or Crohn's disease, you may have heard. And Dr. Chapin outlined some of the other risk factors with respect to our lifestyle. What are the symptoms of colorectal cancer? Certainly blood in the bowel movements are important to take note of. Any change in your bowel habits. If you're a regular person, all of a sudden start being a little irregular. If you're a normally constipated person, now you're starting having diarrhea. What it really is knowing your own system and being aware of a change in your regular pattern. If you start feeling an unexpected weight loss, you're losing weight without actually even trying, certain kinds of abdominal pain or pain down in the pelvis. And anemia, a low blood count, and that sometimes is just found at your doctor's office when they do routine blood work, or a sign of anemia is fatigue. You're just not able to do as much as you used to without getting tired. If you do happen to be diagnosed with a colon or a rectal cancer, understand that the best way to be treated, you'll be seeing a lot of doctors. It's a real multidisciplinary team that gets involved to offer you the best care. Not only do you have me, the surgeon, you have the medical oncologist, we call those the people who deliver the chemotherapy. You may meet a radiation oncologist for radiation treatment, and of course our gastroenterologist, the radiologist, and a lot of the support services that we offer. So you can be part of a big team that's going to help take care of you. So how do we treat colorectal cancer once diagnosis? Once diagnosed, it really depends on the stage, or how advanced, if you will, that the disease is. Generally, the higher chance of being successfully treated for a complete cure is if you have an early stage. The other thing is where in the colon or rectum the tumor is, the cancer is. Colon cancers are treated a little bit differently than rectal cancer. And as I just alluded to, you may be treated not only with surgery, but chemotherapy and or radiation may come into play. So generally, surgery is the mainstay of treatment for early stage cancers, whether it be in the colon or the rectum. Early stage cancers haven't spread to other parts of the body and are really kind of minimally involved with the colon wall. Chemotherapy may come into play if you have a slightly more advanced colon cancer, and radiation may be added to the chemotherapy in rectal cancers. So what are some of the key issues we're going to talk about? When we operate as surgeons, what do we want to achieve? Which operation are we going to offer you? And this is a major fear of patients, and the first question I often get is, will a bag be required, a colostomy bag, and we'll address that. How is the operation done? You've heard probably a lot about open and traditional surgery, or now minimally invasive or even robotic surgery. What are the risks of surgery? How long will it take for me to recover? And are there any additional treatments? So let's start with the goals of surgery. First and foremost, we want to cure you if we can. So we're going to not only get rid of the cancer, but the lymph nodes that it may have spread to. That will help stage you, but the overwhelming majority of patients, the goal is to remove the disease and the lymph nodes. If unfortunately you reached a point where we don't feel that we can cure you of your cancer, we certainly want to help you with palliating or relieving your symptoms of certain things such as a bowel obstruction or bleeding or pain. And of course, first and foremost, quality of life is very important, and we want to preserve your quality of life. So let's talk a little bit about what kind of operations you're going to get. If you have a colon cancer, invariably we are going to be removing part of the colon, a partial colectomy. When we talk about the rectum, and I'll show you some schematics in a minute, one of the things that we're going to do is not only remove part of the rectum, but hopefully we'll be able to preserve the muscles that give us control, sphincter sparing surgery. And we've been increasingly very successful at doing that through the years, such that over the years, fewer and fewer people do need that permanent colostomy. So again, this is the schematic that you saw a little bit earlier. If your colon cancer is on the right side of the colon, as I said, is nothing more than a hollow tube. What we're going to do is we're going to take a little bit on either side of it, remove this part of your pipe, and we're just going to connect this part to that part. Similarly, if you have a problem or a colon cancer on the left side, doing almost an identical thing where we just take a little bit more of the pipe on both ends, remove the colon here, and attach the two ends. And that is what we call a partial colectomy. The rectum I mentioned is a little bit different. It starts really from the anus, if you will, and goes up about 10 inches or 15 centimeters. And we break it up into thirds. We have the upper rectum, the middle rectum, and the lower rectum. Invariably, if you have a problem, a rectal cancer in the upper or mid rectum, then we will be able to do the partial removal of your rectum as well as preserve those muscles, no colostomy. This is where it gets a little bit more tricky. These are the sphincter muscles, and depending on how close your cancer is to the sphincter muscles may determine whether or not you will need that permanent bag or the colostomy. So as I said, and this is what a lot of patients really focus on, the colostomy. As a rule, colon cancer, colostomies don't come into play. Rectal cancers, it may if it's in the lowermost portion. You may need a temporary bag as part of your treatment, but again, for the most part, we don't need colostomies unless we're involving that tumor is getting very close and involving the sphincters. So how do we do surgery? So it's been called traditional, although I will say now that this has been around, minimally invasive surgery has been around for a while. We may be calling that more traditional. But traditional is what we call open surgery, and you may have heard about minimally invasive or laparoscopic surgery. So in traditional surgery, an open surgery, it's an incision that goes right down usually the middle of your abdomen, and through that incision we gain access to your colon, and we do the operations that I had just talked about. In minimally invasive surgery, what we do is we use these tiny little punctures to put in some ports and some working instruments, and then we do the entire operation through the laparoscope. It's a little bit of a misnomer because we still have to get the colon out of you, and we can't get your colon out of these. These are 5 millimeters, a half centimeter. So if you have a 4 centimeter tumor, you're not going to get a 4 centimeter tumor out of a half centimeter hole. So we often do need to make a small incision to remove the colon. This is a view laparoscopically, and these are these kind of trocars, if you will, that we operate through. And this is one of my colleagues, Dr. Newman, who's actually doing one of these laparoscopic procedures. And you can see he's looking at the TV screen and doing the surgery. And that's what he's looking at inside your belly. This is your colon, and these are these laparoscopic instruments that he's manipulating to do his procedure. Now, you may have heard about robotic surgery. In fact, you've heard of just about everything we're now doing with the robot. I think we're getting robotic haircuts soon. And in fact, I didn't know we were doing robotic colonoscopies now. Interesting. So what's interesting about this is, and it's totally available. We're doing it here at NYU. But unlike where you saw my colleague standing by the bedside, that's actually the surgeon. He's operating, and he's looking through this console, and his fingers are attached to the console, which are controlling all of these instruments. So that's what we call robotic surgery. What are the benefits of minimally invasive surgery? Clearly, through smaller incisions mean less pain. We are now having shorter hospital days. I actually operated on somebody last week on a Thursday, went home on Saturday, so some patients are really going home after just 2 days. So quicker recovery and quicker return to your activities of daily living. But most importantly, we've learned through good investigation and data that we're still doing a good cancer operation, and the rates of cancer recurrence and the survival are as good with this minimally invasive surgery as opposed to the open. Complications, we don't like to talk to them, but what are the potential complications of colon surgery? Like any operation, some of the cardiac, heart attacks, pneumonias, infections, bleeding. And one of the things as bowel surgeons we worry about is when we take the colon out and kind of weld you together, in a small but real number of patients, about 2%, that welding springs a little bit of a leak, and that can certainly be problematic. Recovery, you're going to come to the hospital, you'll be in the hospital for 2 to 4 days, but what about after that? People heal at a variable rate, but with minimally invasive surgery, some people are really 100% by 2 weeks. Some people it takes a little bit longer. I tell most of my patients, by 6 weeks, you'll be back to your normal self. During those 6 weeks, the real issue is your energy level. That's what takes the longest to recover. You're not in pain such as it is for 6 weeks. It's really your energy level, because it is, even with a laparoscope, it is still major abdominal surgery. Long-term recovery, really your bowel function is largely unchanged. In a small percent of patients, when we're operating very low in the rectum on those rectal cancers, the nerves are down there, so you may have some impairment of sexual and bladder issues. So in summary, for colorectal cancer, it is preventable and curable. Visit the Dr. Pachapins to get your colon screened and your colonoscopy or virtual colonoscopy. That is the way to roll. And again, you'll see many doctors in the course of your treatment, and this multi-modality team approach is really most important for the best outcomes. You need to seek out experienced teams and experienced centers, and that's what we are here at NYU Cancer Center. So thank you very much for your attention.